Welcome to OncoPharm. I'm your host, John Bazar. I'm a professor of pharmacy practice here at the supporting sponsor of OncoPharm, ETSU's Bill Gatton College of Pharmacy. It is February 12th, 2026, and I'm going to talk about the some updates to some labels from the FDA. So when FDA updates a drug label, they sometimes they'll make a point of alerting you about it. Sometimes they'll do that, and it's impossible to find what that update is. And sometimes it's a little bit harder to find. And so if a drug gets a new indication, there will be a new label that reflect that change. So it'll say, instead of approved for first-line treatment, a better example would be, the old label would say approved for treatment after you fail such and such therapy. After a new approval, it may say approved in the first-line setting, for example. And there'll be new information about the clinical trial that led to the approval. There'll be new safety information. Sometimes other new stuff has been found out about the drug interaction profile or pharmacokinetics or use in certain patient populations like severe renal dysfunction, and that will make it into the label as well. Now, sometimes those things change without an approval. Like a new approval is flashy. There's a press release from the FDA. There's a press release from the company. It tends to get talked about. FDA also makes drug safety-related label changes pretty frequently, and those kind of fly under the radar. And even when you know about them, they can be hard to find. So we're going to talk about two lessons of that this week. So the first is the change to the label for Axi-Cel, Siloleucel, Axi-Cel. This is Yescarta is the brand name, but we call it Axi-Cel. And I don't know if I saw this on social media. Maybe it was an email that I got from some of these services that I never signed up for. And it said something about FDA removes a limitation of use or a hold or allows for the use of Axi-Cel in CNS lymphoma. And so I spent probably 20 minutes trying to find the old label of Axi-Cel because the current prescribing information or label for Axi-Cel on their website and on the FDA's website. The FDA doesn't update their label. We'll come back to that. I could not find a more recent label. Now, that's because Axi-Cel, I don't know why it is, but the usual method is you go to the FDA, there's a database where you can go look up any label of all time that's been there. If you go to drug-related safety label changes, you can see, for example, the October 2025 version of Xeloda. And if there's a newer one, it'll be there. But because Axi-Cel is a cellular and biologic therapy, it's in a different database, and I can't find it. Anyway, I'm just kind of trusting here, because if you go to the Tisangelec-Lucel, or the Kymriah PI, in section 1.2, there's a little clause that says limitations of use, primary CNS lymphoma. And that same limitation of use, it's not a contraindication, it just says, hey, the drug's approved for non-Hodgkin lymphomas, but not this type, primary CNS lymphoma. Well, that language has been removed from Axi-Cel. And it doesn't say it's approved, it's not like an FDA approval for that, but it says the FDA is not saying you absolutely cannot use it for primary CNS lymphoma. And that is because of this study by Lakshmi Nayak and colleagues at Dana-Farber and Boston Children's and some other places in Boston. And this was an investigator-initiated study of 18 patients with CNS disease where they gave IV Axi-Cel for their CNS disease. Now, of these 18 patients, 13 had primary CNS lymphoma. And presumably, I don't know this, and so this is a guess, the reason for the limitation of use is because we know that CAR-T can cause not just cytokine release syndrome, but also this neurotoxicity, this immune cell-associated neurotoxicity, that might be really bad if you have CNS lymphoma. Because if you're killing these cells in the brain, there might be incredible toxicity and swelling that could be, potentially life-threatening. That's my guess. And so this was an investigator-initiated study where they took 18 patients, 13 of whom had primary CNS lymphoma, and they gave them the standard Axi-Cel 2 times 10 to the 6 cells per kilogram after fludarabine cyclophosphamide. There were a few other patients had secondary CNS lymphoma and one that had kind of a mix of some other stuff. And basically and this data for these 13 patients with CNS lymphoma is now in the PI for Axi-Cel under some of the safety descriptions in the warnings precautions sections about cytokine release syndrome and neurotoxicity and ICANS. And again, it's just 13 people, but cytokine release syndrome was 89%. That's kind of consistent with the parent drug, or the drug given in a larger population. Let's see, grade 3 CNS was 0%. Can't get lower than 0%. ICANS was 44%, 28% grade 3. And these are kind of in line with what the toxicity is when using Axi-Cel to treat systemic disease. And so I think that seems to be the reason why FDA removed this limitation of use for Axi-Cel. Perhaps that will follow for other drugs as well, if they are studied. For my purposes, I had never considered using these drugs for CNS lymphoma, but now it is a consideration. It has been studied. And not only does it appear to be safe, but we have a response rate here. Now, this investigator-initiated study was presented as an abstract. ASCO in 2024, ASH in 2022. I can't find it published, and I wasn't able to find just the CNS lymphoma data. But of the 18 patients total, some of these are secondary CNS lymphoma. The response rate was 17 out of 18, complete response 12 out of 18, promising progression-free survival of 14 months and median OS of 26.4 months. But patients, 7 of the patients did die from disease progression. So it is something, if you have somebody with CNS lymphoma that's refractory to everything, it's worth referral to a place that does CAR T if you don't do it, to at least think about it, I think, in this scenario. And so based on this investigator-initiated study, which, because there's a limitation of use, they had to get, an okay from the FDA to do the study, probably. Well, maybe not from the FDA because they weren't going for the approval, but they had to get approval from their IRB, certainly. And they also had to get approval from the drug company, probably, to be able to use this and to do that. And so I think that's really interesting. That's the way things are supposed to be done, is on a clinical trial with the results widely disseminated for everyone to review and comment on. And then the FDA updated the label so we could see that. And, the drug company put out press releases so more people would know about it. Now, last week, FDA also, I got an email. I saw a tweet. I commented on the X on the tweet. The FDA didn't get back to me because they said that they have changed the label for 5-FU, 5-fluorouracil, and Xeloda about DPD testing. And I read the description of it. I was like, well, this sounds like what they already did. Because they did this for Xeloda in October of last year. But they did not update the label for 5-FU. So I've spent multiple times looking, is there a new update to the Xeloda label? I don't see a new label. I don't see a new label for 5-FU either. But presumably, what has now been said is FDA is saying test for DPYD deficiency before giving a dose of 5-FU. That, in my opinion, that was already implied when they said that about Xeloda at the end of last year. So that is almost a formality, but it is a formality, but also a frustration because I can't actually find the new label for fluorouracil. I can go find the last label of Xeloda, of capecitabine, but not for 5-fluorouracil. So, and the press release doesn't... the FDA website is bothersome. With AI these days, you can do so much stuff. Why can't AI redesign the FDA website to make it usable? Why not? Can we? Please. All right. Enough of my ranting about artificial intelligence. The last thing I want to talk about is, from a drug standpoint, is this approval of pembrolizumab again with paclitaxel for platinum-resistant ovarian cancer or fallopian tube or primary peritoneal carcinoma. This is based on Keynote B96, which was a study I considered talking about in my ESMO 2025 recap, but I cut it because it was a second-line study. It hadn't been published yet. It still has not been published. But this is a fairly large study of patients with ovarian, fallopian tube, or primary peritoneal carcinoma who were platinum resistant. So their cancer has come back really fast after their platinum-based chemotherapy. So they're given pembro or paclitaxel 80 per meter squared on day 1, 8, 15, and then skip a dose, and then every 28 days. And the approval is just for those who are PD-L1 positive based on composite proportion score, which includes PD-L1 stating not just on the tumor, but other cells in the tumor microenvironment. The median OS was 18.2 compared to 14 months, and those who didn't get pembro, that hazard ratio of 0.76. 95% CI, 0.61 to 0.94. The median PFS was 8 versus 8.3 versus 7.2. So it's modest benefit, but you do see a significant overall survival benefit, but just in the PD-L1 positive cohort. So, modest benefit is still benefit. So this is nice to see another approval in pembrolizumab's a hat. And then I said that's the last thing I want to talk about. One other thing I want to talk about, checking back in with the Pit. Still a lovely show, set in an ER in Pittsburgh. Every episode is an hour in a shift, 7 a.m., 8 a.m. We're almost getting to lunchtime now in the season. And just as a check-in, still have not seen a pharmacist here. I know pharmacists work in the ED. They're very important in the ED. Still haven't seen a pharmacist. I have seen a patient on the show who was sharing meds with their family and took like 4 propranolol tablets and was really orthostatic and bradycardic. Would have been a good intervention of a pharmacist to talk to them about this. Saw somebody get vancomycin, no pharmacy to dose. Maybe that's fine, probably is fine, but maybe not what you would see a lot of times in the real world. I do have a couple cancer patients floating around this season of the Pit. There's a patient with a brain tumor that maybe is the reason for a change in this person's mental status and their mood going back years. Something that I have seen is a patient with cancer, and I saw this patient on a psych rotation because this person was thought to have a mood disorder. Months later, it was found out that it was a cancer that did it. So that does happen. Those things do happen. And then there's a patient with metastatic cancer pain who is revoking hospice for some other reason, I think it was, coming into the ER. So there are some cancer patients floating around there still waiting to see pharmacists make their mark on the Pit. But it is a very good episode, or a very good series. I encourage you to check it out if you have access to HBO Max. That's not a paid advertisement. I mean, if the Pit wants to market on here, I will accept that cash to do so, because I support the show. Okay, that is what I have this week. Thank you so much for listening. I will be back next week. You can follow me on X at FarmDNib and other social media platforms at UncleFarmPod. And until I talk to you again, remember, doses matter.